on 19th of October with an altered behavior for last 2 days. She was also complaining of a productive cough, non-bilious vomiting for last 1 week, preceded by a generalized weakness and loss of appetite for last 3 weeks. On further history taking, she was a mother of 2 sons. She was oligomanic for last 13 years of last childbirth. Lactation though was normal, she was complaining of hoarseness of voice for last few months. The main complaint of the patient was recurrent vomiting for last 2 years and which need hospitalization, and she was treated for acute gastritis, acute gastroenteritis. On admission, the patient was drowsy, she was in shock, and further she improves with the fluid resuscitation and inotropic supports. There was on admission there was a low saturation. There was few scattered crepes on the left upper lobe of the lung. On investigations, she was hypoglycemic with CVG 40. She was having neutrophilic leukocytosis, hyponatremia, and there was some patchy opacity over the left upper and left middle lobe of the lung. And UVG sonography of the abdomen shows distended bowel loops. So on clinical suspicion of a oligomenorrhea with a hyponatremia, hypoglycemia, and the patient complained of generalized weakness, asthenia, we went for a hormonal study. And in the hormonal study, we shows that there is a decrease of the thyroid hormone with not increment of the thyrotropin. The corticotropin is low and ATM cortisol was low than the normal range. The gonadotropins were also low. And MRI shows the anterior pituitary hypoplasia. So we diagnose the case as a case of hypopituitarism. These are the normal value within the brackets showing the normal value. It is slightly different from laboratory wise. Now we treat the patient with resuscitation, inotrop, antibiotics, steroid therapy, and the thyroid hormone replacement. Shift the patient to the CCU on day 2, but gradually the patient developed a sepsis with acute kidney injury. We have given the base treatment with the change of antibiotic, hemodialysis, but the patient expired after 7 days. Now my next case is a 38 years old lady from Gugumali, Jalpaiguri, admitted in our hospital on 20th of November with altered behavior for last 1 day. She was not taking a food for last 2 weeks, severe constipation for last 1 month with intermittent vomiting for last 1 year. She was a mother of 2 daughters, and during the last childbirth, she needed blood transfusion. Lactation was though normal. She was oligomanic for last 18 years and amenorrhea for last 7 years. She was having a severe asthenia for last 10 years. Multiple hospitalization was given for severe constipation. On admission, the patient was drowsy. She was in shock. Saturation was not recordable. There was anemia, edema, and the neurological, she was drowsy. Now on investigation, there was hypoglycemia, CVG was 36. She was having anemia, hypoalbuminemia, and hyponatremia. Sonography shows distended bowel loops. So with this clinical suspicion of a prolonged 17 years of amenorrhea, oligomenorrhea and amenorrhea, we went for a hormonal study. And in the hormonal study, we shows a low thyroid hormone of 0.3 T3 and 4 T4, low corticotropin, IGF-1 was very low of 48, and prolactin was also low. Though the gonadotropin was normal in that time, and the thyrotropin was 7.14, slightly increased. There was distended bowel loops in the chest X-ray and showing the abdominal part. Now the MRI shows a empty cella, severe hypoplasia of the pituitary. My third case was a 38 years old lady from Uttar Dinajpur, admitted in our hospital on 23rd November with a generalized weakness and loss of appetite for last 2 years and increase for last 2 weeks and occasional vomiting for last 3 years. She was having a typical history of severe bleeding PPH during the last childbirth with need 5 units of packed cell transfusion, lactational failure, amenorrhea for 17 years, though unnoticed, and gradual hoarsening of the voice for last 10 years. Constipation, anorexia, rest normal, hypoglycemia of CBG 56, hyponatremia, and showing some distended bowel loops. We go for the clinical suspicion. We think about Sheehan. We go for the hormonal study. Shows secondary or pituitary cause of hypothyroidism, low prolactin, low corticotropin, low gonadotropin, and IGF-1 of 41. And this is the MRI of that patient, shows anterior pituitary hypoplasia, and there is some gliosis in the left frontal lobe. My last case is a 26 years old lady from Jalpaiguri with severe vomiting for last 7 days and fever with productive cough for last 1 year. She was married of 1 child 6 years back. There was a history of blood transfusion. Lactation was normal in this patient. There was oligomenorrhea for last 2 years. Severe anorexia, cachexia. She was drowsy on admission with hypotension. Saturation was 96. She was febrile with anemia, edema, and there was coarse crepes with a bronchial sound in the left upper lobe of the lung. There was leukocytosis, anemia, hyponatremia, hypokalemia. There was the CSF or CT brain was unremarkable, and HIV report was non-reactive. She was having hypoalbuminemia. Chest X-ray shows patchy opacity in the left upper lobe, confirmed with CT scan having a consolidation with cavitation in the left upper lobe, suggestive of tuberculosis. The sputum AB became positive. So with this clinical suspicion of a sudden onset amenorrhea for last 2 years with a severe asthenia, we go for hormonal study, and we found all the pituitary, anterior pituitary hormones are decreased. Though the MRI pituitary shows a normal structural pituitary. So we treat the patient with initially the resuscitation with the fluid, inotrop, blood transfusion, antibiotics, steroid, levothyroxine, ATD, and discharge the patient safely. So these are the cause of anterior adult hypopituitarism. The most important of these cases are Sheehan, tuberculosis, the adenomas, the tumors, and others. Now, regarding the linking of the unlinked cases, the first case was of a oligomenorrhea patient having complaint of vomiting for several years, recurrent admission, unnoticed, and finally diagnosed as a case of hypopituitarism, Queria Sheehan, without a proper history. The second case was a case of amenorrhea, PPH, lactation was normal, then amenorrhea, presented with hypoglycemia, hyponatremia, and in shock, is a case of Sheehan with a normal lactational history. The third case being the classical Sheehan with a PPH, lactational failure, and then amenorrhea, and finally the patient became presented in a hypoglycemia, hyponatremia, and in shock. The fourth case is a case of disseminated tuberculosis with a very functional hypopituitarism with a normal structural pituitary. So there is a case report in British Journal of Tuberculosis and Disease of the Chest showing the functional hypopituitarism in advanced chronic pulmonary tuberculosis. So hypopituitarism, these are the 4 cases we got within the last 1.5 months, and these cases are of hypopituitarism which is often unnoticed for several years. So this is not as rare as we think, and these are quite common in our wards. Thank you.